This is part 2 of obstructive sleep apnea. In this part, mainly we are going to deal with what are the body changes in those patients with sleep apnea, and about the habits and about the past illness whatever the patient has, and how it affects the sleep apnea condition, and the patient complaint as well as the examination and investigation. Let us go through that. Now, if it's better that you watch the part 1 and then you watch part 2, because you have a clear-cut idea in that case. So in that in part 1 I have already explained that you get the person diagnosed as sleep apnea, he gets obstructive sleep apnea, he gets obstruction from the nasal cavity up to the vocal voice box, and mainly behind the nose and the oropharynx. That is the main part. So what happens during sleep? Because of the obstruction at 3 different levels, the muscle tone comes down and it obstructs, it collapses. Because of that, there is no proper oxygen supply to the brain. So because of this change, there are so many body changes, changes in the body. So what happens is, if during sleep, normally the heart rate should go down and it should stay steady. When in a case of sleep apnea, when the patient has got breath holding spells, this heart rate will not be steady. It keeps on fluctuating from the minimum to the maximum. So this variation, wide variation in heart rate, it can lead to conduction defects in the heart, and it can lead to problems in the heart like heart blocks. Then there is arrhythmia defect. Arrhythmia means the conduction defects, and the chances of getting an ischemic heart disease is very high. Likewise, since there is oxygen level is very low and the general metabolism doesn't happen in the body, you have other conditions like he may develop hypertension, or especially if he is already hypertensive, his hypertension or blood pressure will not be easily under control, especially in a severe case of obstructive sleep apnea. And if he is diabetic, his blood sugar level will not be easily under control if it's a case of severe obstructive sleep apnea, severe case. Likewise, getting a chance of a stroke is very high. And the most important thing, if it's a severe case, there is a very high risk or possibility of sudden death at the bed too. And what the general explanation, we hear that he was okay in the night and he went to bed normally, and when you but he didn't wake up in the morning. So maybe it's a silent attack. So sudden attacks, silent attacks are more common in these type of patients. So now, if he has a habit, this patient of sleep apnea, if he has a habit of if he is a smoker, his condition becomes worse. Likewise, if he is alcoholic also, and he is a patient of sleep apnea, his condition can worsen up fast. Same thing to add up, if he is taking any sedatives, the problem still increases more. If he is already a patient of diabetes, like how I explained, hypertension, he has got a thyroid problem, cardiac problem, and lung diseases, all these diseases is going to be exacerbated and is not going to be well controlled, only because he has got a condition called obstructive sleep apnea. Now, let us deal with the complaints of the patient, and for ease of understanding, I will break up into complaints during night and complaints during day. So, the night complaints will be starting from the primary stage, which you have to see in the part 1. The main complaint will be the partner complaint, the person who is sleeping with the patient, they complain that he has got snoring. He snores a lot. That is one. As and when the stage increases, he becomes worse. What happens is his sleep is fragmented and he keeps on moving in the bed. He turns to the left, then becomes straight, then he turns to the right, and he moves his leg too much. So there will be a lot of movement during sleep, which he doesn't realize at all. And in the worst stage, what happens is there will be gasping, choking spells, and suddenly he gets up. That is what happens at night. Now, during the daytime, next day morning, such a patient, when they wake up, they complain they have a headache. The reason being his carbon dioxide level in the blood is high. That's why. Why? Because the oxygen level is less. That's why. So he gets an early morning headache always. And when he wakes up, he is not fresh at all. He feels like he wants to go back to sleep, but if he goes back to sleep, he will not sleep fast. The whole day is tired and he is irritable. He has got loss of concentration, loss of memory. He has become irritable for small things. And there will be memory loss too. And along with that, there will be some of the patients, they say that we have been referred by the physician because we gave him a history of snoring and our blood sugar or our blood pressure is not getting controlled. So that also can be one of the presentation. Now the most important and the most dangerous complaint will be these patients in a severe stage. What happens is, even during a common meeting when they are sitting with somebody in a group, they tend to sleep off. Or when they are watching a TV, they tend to sleep off. And still more dangerous, when they are driving and they stop the car on the signal and they get a few seconds, they don't realize they sleep off. That is really dangerous. And when they are driving, they are in the long run, they tend to sleep off and they may meet with an accident. That is the deadliest one. So all these complaints possible in an end stage. So suppose the person in a meeting he sleeps off, most of them say maybe he was working overnight and that's why maybe he is tired, maybe he was concentrating on the project which he wants to discuss now. The answer is not that. The problem is he has got a sleep apnea. Ask him to go and meet an ENT doctor and get it rectified. Okay. Now, so these are the complaints of the patient. Now coming to examination, we to start with, we'll check his pulse rate, we'll check his blood pressure, and we'll check his height and his body weight. And with his height and the body weight, we'll see what is the body mass index, and we have a grading for that. Grade 1, grade 2, grade 3 and grade 4 is severe, which is more than 40, which is severe. And we'll examine his neck circumference. See, his neck circumference, suppose it is more than 17 inches in males, then the chances of having sleep apnea is very high. Likewise, his abdominal girth in males, suppose it is more than 94 centimeters, the chances of having sleep apnea is going to be high. And the neck circumference, we have importance even during the treatment part. I will tell you later on how important this is. Now, we have to examine the whole face as one unit. We will see that whether his maxilla bone here and the mandible bone here is retracted, which means it has gone back or not. Why? Because suppose it has gone back little bit, like this part has gone back, means the airway behind is compromised and he will not be able to breathe well, especially at night. That's why we assess that also. Now, coming to examination of the oral cavity, whether he has got an adequate mouth opening, so that it is easy for us if we need to operate on him. Then see the size of the tongue, whether it is normal tongue size or it is macroglossia or bigger in size, whether his teeth alignment is same or it is malocclusion is there or not, whether his palate, this part is called palate. Palate is redundant and whether it is low lying or not. So it is obstructing or not, and the tonsils, whether it's completely obstructing, that is, we grade it into 4 different categories. That is, obstructing completely is called type 4 type, whether it is there, and even the posterior and the lateral oropharyngeal part is redundant or not. These are the things we watch in the oral cavity and oropharynx. Now, so examination part is over. We have to do some normal procedures like nasal endoscopy, nasopharyngo-laryngoscopy, like how you see in this picture. So, by doing this, I will come to know, is there any obstruction starting at the level of nose up to the voice box. So, I am seeing here structures which are rigid and structures which are collapsing. So, the structures which are collapsing, which is mainly behind the nose, which is called as nasopharynx, and the part which is behind the oral cavity, which is called the oropharynx. And in that particular part, I am going to do 2 special tests to see whether it is obstructing or not. So, first I will do a normal nasopharyngo-laryngoscopy to assess the airway. Is there any obstruction or not? Once that is done, I will do a maneuver called Muller's maneuver and another one N-expedited tongue based position, where I will come to know the collapsible part, how much percentage it is collapsing. That is one. So, once I come to know how much percentage is collapsing, I am going to grade it. I will tell you in the next slide. So, after that, the main diagnosis for a case of sleep apnea, the golden standard is going to be, I will ask for a sleep study. So that is called as polysomnography. And the last one being drug-induced sleep apnea. So whatever I am doing here, the first part, the patient is awake, he is in the OPD, I do an endoscopy. So I am doing an endoscopy and trying to find out something, some problem which he has got during the sleep and not during the day. So the better idea will be such patients where I know that he has got a problem and he got a sleep apnea, which this nasopharyngoscopy is giving me an picture that he has got a sleep apnea. These type of patients, I like to take him to the operation theatre, and with the help of the anesthetist, I'll sedate the patient to the level that he just goes into sleep and his oxygen level drops down and he starts snoring. That time I will introduce a camera or the endoscope to see at that what particular level he has got obstruction and how much is the obstruction. That is, he is mimicking a normal sleep, and now I am going to find out how much obstruction he has got. So I am by nasopharyngoscopy, I will examining from this part up to the voice box. So I have told you that nasopharyngoscopy, if I find an obstruction at the collapsible areas, that is behind the nose and behind the oral cavity, I am going to stage the obstruction. So the obstruction can be at 4 different levels. So that I will grade and find out how much percentage is the obstruction, and likewise I will enter here how much percentage. This obstruction can be only on the lateral wall, or it can be anterior posterior, or it can be circumferential. That also I will note it down. Now coming to investigation. So this investigation which I am going to mention, it is not for the diagnosis of sleep apnea. The mainly for diagnosis of sleep apnea, the golden standard is going to be polysomnography, and nasopharyngoscopy and sleep endoscopy helps me for that. So this investigation is only to find out what are the secondary effects of sleep apnea, and if suppose we are going to plan for the treatment, whether it be medical treatment or non-surgical treatment or surgical treatment, this investigation is going to help us. So I will do a few investigations starting from blood, hemoglobin, coagulation protein, D-dimer. Likewise, I want to know the ECG and chest X-ray and echocardiography, because these patients, like how I explained before, they tend to have cardiac problems and which is not well under control. So I like to do all this and have a cardiology consultation too. Likewise, I'll do a complete thyroid function test too, and especially I want a urine 24 hours urine catecholamine. If the patient got sleep apnea, the urine catecholamine level is going to be high. There is a new investigation which has been recently introduced. Likewise, chest X-ray and MRI scan lateral view. So more than MRI scan, I will depend on other investigations like polysomnography, drug-induced sleep endoscopy and nasopharyngoscopy. So now coming to polysomnography, that's a gold standard. Here the patient, he comes into the hospital, or maybe it is done at home. We do not inject anything, no cannulas, nothing. We just fix a small gadget here, and we have oxygen saturation and the ECG connector and so many wires which is connected in the face, in the head and behind the head also. And he goes to sleep as usual. And we need a minimum of 4 to 6 hours of sleep to get a good report to score. So that 4 to 6 hours of sleep is enough for us. Now, once that is done, we get an idea whether he has got a sleep apnea or not. That means we are going to diagnose whether he has got a sleep apnea or not. If he has got a sleep apnea, then whether it's a central one, obstructive one, whether it's a mixed one, that means we are classifying it, and we come to know how severe the condition is. That's why I said this is the gold standard for diagnosis. Now, this sleep apnea, polysomnography, which I have told you now, it can be of 4 types. If it is a hospital based, where you have a very good room and the video is already connected in that room, the patient sleeps in that particular room, and outside the room we have a computer panel and a few staff who is monitoring the patient from outside with all the gadgets and everything. He is fully monitored. That is type 1. This is hospital based. Rest all type 2, type 3, type 4, which can be done at home. So the same parameters which we are going to do in type 1, the same parameters can be measured in type 2, but there is no video camera, nothing, he is not in the hospital, the whole thing to be done at home, so but it is not monitored. Now type 3, which is again done at home, it can be done at home, the number of parameters which you are going to check is going to be less, like we are checking only 4 to 5 parameters, and mainly EEG, the central arousal, we are not going to check. The last one, the basic one, here type 4, we are checking only oxygen desaturation, which gives us an idea whether he has got the disease or not. With that, we cannot have a complete diagnosis, we cannot classify it, we cannot know the severity of it, but we can know, we can say that he has got this condition, he has to go in for higher test. So these are the four types of polysomnography. In this, I will prefer type 2 and 3 for my patients, depending upon the findings. So when the polysomnography is done, the next day morning, or we need one day at least to get the report. So when you get the report, the front page, covering page, will have a few points like this. The first being whether he has slept well or not, his sleep efficiency is there or not. If he has slept well for 4 to 6 hours and his sleep efficiency is 90%, then I can clearly say all these readings, other readings is going to be correct. That is one. Second is, I am going to see the severity of the condition. That I will come to know by doing an apnea hypopnea index, which I have already explained in part 1, whether it is mild, moderate or severe. Please see part 1 to know that. Then, how much is the oxygen desaturation during the sleep? And how much is the mean and how much is the lowest? Likewise, I would like to know the pulse rate. How much is the minimum pulse rate? How much is the maximum pulse rate? How much is the average pulse rate? And the last one being whether he has got a secondary cardiac arrhythmias or not. This is what I want to know. So this is all about polysomnography. So this second part, I have mainly dealt with the patient complaints, what are we examining, and the investigations. So please do watch part 3 and part 4. In part 3, we are going to see mainly about, we are mainly going to see about non-surgical management, and part 4 we are going to deal mainly with the surgical management. Thank you so much.